Welcome to the Pupil Pod, where we use clinical cases to guide discussions on board review topics. I'm your host, Ogul Uner, and my guest today is Dr. Kareem Moussa. Dr. Moussa is a vitreoretinal surgeon, uveitis specialist, and associate professor of ophthalmology at University of California, Davis. Dr. Moussa, thank you so much for joining me.
Thank you so much for having me, Dr. Uner.
Great, let's dive directly into our case. We have a 30-year-old gentleman who presents to your clinic with right eye pain, redness, and photophobia for the past 3 days. He reports the eye pain occurred suddenly and has been getting worse. He had a similar episode in his left eye about a year ago that was treated with a drop, but he can't recall its name. He denies prior trauma or ocular surgery and appears generally healthy. Best corrected visual acuity is 20/30 in that right eye and 20/20 in the left eye, with an irregularly shaped pupil in the left eye. IOP is 9 in the right and 16 in the left. His anterior segment exam shows few small chorotic precipitates, 4+ anterior chamber cell, and a 0.5 millimeter hypopyon in the right eye, and an otherwise quiet eye with posterior synechia. His vitreous and posterior segment exam is unremarkable in both eyes. Dr. Moussa, what are your thoughts about this case, and what additional questions would you like to ask this patient?
Thanks for providing that excellent history, Dr. Uner. I think that really helps us hone into a few key features that will be very useful for both potentially diagnosis and management for this patient. So looking at this patient, I think the first important thing, which you've done for me, is to get a good history. And based on the history, I now know that this is a problem that's not only occurring in the right eye, but has also likely occurred in the past in the left eye. We see some findings on exam that indicate that there was likely some past inflammation in the left eye as well. And based on the exam findings, we know that there's active inflammation currently going on in the right eye. So I want to know how many times has this happened in the past? And based on this history, I already know that this is alternating, and this is a key word. This is an alternating process. It's not recurrent solely in one eye, but it's occurring in both eyes. And I want to know how he was treated in the past for this process. Was he treated? Was he not treated? And I also want to know if he has any other systemic symptoms or signs. So I'm already honing in on uveitis. This is a case of possibly anterior uveitis. I'm not sure if we're done evaluating the posterior segment, so we haven't yet maybe fully classified this into anterior, intermediate, or posterior. But often we have systemic associations with eye inflammation, and I want to see if this patient may have other signs or symptoms that may help clue me into a diagnosis that is more systemic and including the eye as a part of the disease process as opposed to the sole site of inflammation.
Great. And when you ask more questions to the patient does report some back pain that improves with activity and is relieved with ibuprofen. His bowel movements are regular without bloody stools. He is monogamous with no history of sexually transmitted infections and doesn't report any recent illnesses. He denies IV drug use. And as he said, this occurred in the left eye before, but he doesn't recall exactly what he was treated with. He remembers a drop, but that's about it. How does this change your approach, and what would you do next?
So I think getting a good sexual history, as you have done, is important because we know that eye inflammation can occur in the setting of sexually transmitted diseases. And one disease that I would like to strongly consider for a patient who comes in with eye inflammation is syphilis. Sounds like this patient is potentially low risk for developing this, given he's monogamous and potentially in a committed relationship with this partner. I would still recommend testing this patient for syphilis to be absolutely certain that we're not treating a potentially infectious process without including antibiotics or antivirals that may be needed. With his history of back pain and this alternating anterior uveitis, I have light bulbs going on in my head telling me that this may be ankylosing spondylitis. And this is a systemic disease in which lower back pain is a key feature. And it's a little bit different from the typical back pain that patients get just with, life and age and strenuous activity. It has a few differentiating features. I would ask him those specific questions to see if this sounds like ankylosing spondylitis. And with that history and with this exam of an active, unilateral, alternating anterior uveitis, I would strongly consider a referral to rheumatology to further delve into this back pain and see if this might be ankylosing spondylitis, which may have significant implications for treatment.
I think you nailed it really well. You wanted to order the infectious labs, ankylosing spondylitis being high on your differential diagnosis, especially pain that's improving with activity. Stiffness in the morning are classic features. So maybe we're thinking an HLA-B27 associated uveitis. You mentioned that you had different keywords like alternating and anterior uveitis. Could you talk more about the anatomic compartments of uveitis? What does anterior uveitis mean?
So anterior uveitis means that you have inflammation in the anterior part of the eye. And when we say the anterior part, we're specifically referring to the anterior chamber. So that space between the cornea and the iris. If you have inflammation in that part of the eye, you have anterior uveitis. Now, one thing that I think is important to recognize is when you have anterior uveitis, sometimes you have a few cells that you can see in the middle part of the eye as well. And by middle part, I'm referring specifically to the vitreous. With anterior uveitis, often the primary site of inflammation is the ciliary body. And when the ciliary body is inflamed, it can release these white cells, which for the most part go into the anterior chamber. But a few of them might be released into the anterior vitreous too, because the ciliary body overlaps with the pars plana, and those cells can appear in the anterior vitreous. If you see a few cells in the anterior vitreous, but the predominant site of inflammation is the anterior chamber, this is still an anterior uveitis. So we have another word that we use to describe inflammation that is predominantly in the middle part of the eye in the vitreous. That word is intermediate uveitis, but I would not call a patient like this who has anterior cells and maybe a few cells in the anterior vitreous as having intermediate uveitis. That patient still has anterior uveitis. If you want to be specific, you might want to call it an iridocyclitis. That means that both the iris and the ciliary body are releasing inflammatory cells into the eye, but I would refrain from calling that intermediate uveitis. When we think of intermediate uveitis, we're really considering another group of diseases that may be the etiology of this inflammation. Now, another site of inflammation in the eye is, of course, the retina and the choroid. Technically, the uvea is referring to the iris, the ciliary body, and the choroid, not the retina, but we do consider inflammation in the retina to be a part of posterior uveitis. And with posterior uveitis, the predominant site of inflammation is the back part of the eye. So inflammation in the retina or the choroid. If you have chorioretinal lesions, for example, if you have granulomas, this would count as having posterior uveitis. A common mistake that we sometimes see is you'll get a fluorescein angiography on a patient who has inflammation, whether it's anterior inflammation or intermediate inflammation, and of course posterior. And you'll see that there's some leakage of dye in the peripheral vessels on the fluorescein angiography. And some may call this posterior uveitis because there's posterior involvement, but that's actually incorrect. We would like not to do that because it doesn't fit into the criteria that have been described by Sun. This was a group of uveitis specialists that put together these criteria so that we all use the same terminology when we're evaluating these patients. It's almost expected that if you have a severe amount of inflammation in the eye in any compartment, you may see some inflammation of the vessels on the fluorescein angiography, and you might see this leakage in the peripheral retina. It doesn't mean that the patient has posterior uveitis because the posterior segment of the eye is not the predominant site of inflammation. Similarly, you can have cystoid macular edema as a complication of anterior uveitis, intermediate uveitis, or posterior uveitis. And having cystoid macular edema, or CME, also does not give you posterior uveitis. We would refer to that as CME as a complication of anterior uveitis, intermediate, or posterior. So just to summarize that, for a patient to have a diagnosis of posterior uveitis, you want to see chorioretinal lesions that indicate that there's inflammation in the retina or the choroid. And if you have leakage on fluorescein angiography in the peripheral retina, that doesn't mean that you have posterior uveitis. You can see this actually not infrequently with both anterior and intermediate uveitis.
That's a great summary, and I think it's very important to really harp on the fact that retinal vasculitis and cystoid macular edema are really outside of this grading system. In most cases, when we think of peripheral retinal vasculitis, we think of it as a component of intermediate uveitis, and that if we do have lesions in the retina or choroid, as you said, that's posterior uveitis. So thank you for that detailed explanation. Moving back to the patient with anterior uveitis, what are some clinical exam findings that we can see?
So I think it's important to do a complete exam from front to back. So when I see a patient who has anterior uveitis, I will first look at the eyelids. Are there any lesions that I see in the eyelids? For example, if there's vesicles that we see on the eyelids that may suggest a herpetic etiology, that's an important feature for us to note. Next, I will take a look at the conjunctiva and the sclera. Is this just a uveitis where there's inflammation inside of the eye, or is there also an associated scleritis, which may also influence my differential diagnosis? So I will lower the eyelids. I'll have the patient look up, look left, look right. I will then lower the upper eyelids and have the patient look down. I want to examine the complete conjunctiva and sclera and see if there's any other sites of inflammation on the outside part of the eye. Next, we take a look at the cornea. And this can actually be easily missed if you're not taking a close look at the cornea. You want to see if there's any abnormalities on the epithelium, and specifically, do we see any dendrites, any pseudodendrites? If I have any suspicion of this, I may put in a drop of fluorescein to help me determine if there's any dendrites. Fluorescein and or tetracaine or proparacaine, these things will numb the eye. So one step that I think that can be really useful is to check corneal sensation before instilling these drops in the eye. Because as you know, Dr. Uner, with some herpetic causes of uveitis, you may have decreased corneal sensation. So in the clinic, I'll take just a piece of dental floss. There's other ways of doing this as well, but I will gently touch the front part of the eye, the cornea, with a piece of dental floss, and I'll make sure to compare that with the other eye. Because if you're only analyzing one eye, it can be hard to tell, is this normal, is this not normal, the degree of sensation that a patient has. But if there's an abnormality, it's usually easily detected by comparing the sensation in one eye to the other. And anterior viral uveitis tends to be unilateral. It's very uncommon for it to be bilateral. So if a patient has decreased corneal sensation that is affecting one eye, I will seriously consider viral anterior uveitis as my diagnosis. After looking at the corneal epithelium, I will then take a look at the stroma. With anterior uveitis that's herpetic in etiology, sometimes with sarcoid as well, or syphilis, we may see some stromal changes. So I want to note where in the stroma is this inflammation and to document it. Is it in the front part of the stroma? Is it in the back part, in the middle part? Does it look fluffy and active, or does it look like an old scar from maybe previous inflammation? I will also take a look at the endothelium. I want to see if there are inflammatory deposits on the endothelium that we call keratic precipitates. These can indicate active inflammation. I want to note where they are located. Are they located inferiorly? Are they located in a triangular pattern inferiorly, which tends to suggest potentially a granulomatous disease? Are they large? Are they small? Are they fine? Are they spread all throughout the cornea, which is more so what we see with viral anterior uveitis? These things are important for us to know so that in the future, when the patient returns for follow-up, we can compare our previous exam with our current one and see, is this getting better? Is this getting worse? Are we on the right track? After looking at the cornea, we want to look in the anterior chamber. The first thing I look for, which is usually the easiest thing to detect, is anterior chamber cell. You want to make sure the room is dim, that it's not just dim actually, but just super dark as you can get it to be. Sometimes depending on where your exam rooms are, it's hard to get the room to be completely black. For example, if you're examining this patient in the emergency department, often it's hard to turn the lights off in the entire ED, but if you can get the room as dark as possible, that will really help you see these white cells in the anterior chamber. And specifically, you want to look at a 1 millimeter by 1 millimeter area in the anterior chamber. So you use your slit lamp beam to do that. And you want to try to count the number of cells that you see on average in each 1 millimeter by 1 millimeter beam. And based on the number of cells that you see in that 1 millimeter by 1 millimeter beam, you can then quantify the amount of inflammation that is in the anterior chamber using the Sun grading criteria. We can go through the different levels if you'd like, Dr. Uner, you let me know, but I'm happy to talk about the different grades that we have to grade anterior inflammation. But at minimum, you want to note if there are cells in the anterior chamber or not, and the severity of those cells. The second thing you want to look at is flare. Flare is this cloudy appearance to the anterior chamber. And in a case like this where one eye is active, you may want to compare to the other eye and you'll be able to tell, oh yeah, the anterior chamber looks a lot more cloudy in this right eye. And this is an important feature, just like cells, so that over time we can see if this is getting better or worse. One thing to note about flare is that it can really lag behind the amount of cells that you have in the eye. So don't be alarmed if a patient has 2+ flare when you first see them when they're active. And a month later, you have other signs of positive response to treatment, like reduced cells in the anterior chamber, but you still see that 2+ flare. Sometimes it can take quite a while, many months, for that to get better. I tend not to advance treatment based on the amount of flare alone that I see. I look for other signs of inflammation to help me guide management, but I do think it's good to note in your exam the amount of flare that you see, because if you do see an increase in the flare on follow-up, that may suggest that there's been a change in the status of the activity of this eye in the interim. Other things to look for in the anterior chamber are hypopyon. Hypopyon can indicate that there is severe inflammation in the eye or potentially infection. When we see hypopyon, we certainly want to rule out infection because that tends to indicate that the amount of inflammation is severe, and we don't want to miss an infection in cases like that. We also want to look for fibrin. So fibrin typically is this stringy material that you can see floating around in the anterior chamber, and sometimes you'll see it piling up on the lens, causing adhesions between the iris and the lens, which can eventually lead to posterior synechia. That's an important feature to note so I can, again, better assess this patient and follow up. After looking at the anterior chamber, I will then look at the iris, and key features to look for in the iris are 1, nodules. Nodules indicate that there is likely granulomatous inflammation in this eye, which is important for our differential diagnosis. I would also look for patches of atrophy in the iris. So when we see atrophy of the iris, 2 things that I would strongly consider are, 1 is this herpetic. Herpetic disease will often cause atrophic changes in the iris, specifically HSV or VZV. If this patient is pseudophakic and I see patches of atrophy in the iris, one thing I would think about is, could the lens in the eye potentially be rubbing against the iris and inducing inflammation by that mechanism? Now, this is a mechanical cause of uveitis, and that's something that we may have to address surgically to rid this eye of the inflammation. I gave you a lot of features to look for in the eye. I think if you do an exam that includes all of these features, you're well on your way to accurately diagnosing this patient and hopefully treating them. But those are the main features I would look for.
I think that was such a comprehensive summary, so thank you for that. And just to summarize, the vision can be variable. We talked about cell, we talked about flare, we talked about hypopyon, which I think is really important. In this patient, we also saw a low IOP. That tends to be the case for most uveitis except for viral. So if the IOP is high with inflammation, I think that's a concern for a potential viral or other infectious etiologies. And we talked about the granulomatous features. And so moving on to the laboratory and imaging tests, what would you order on patients with anterior uveitis?
Very good question. I think the first thing I'll start off with is you actually don't always have to order a workup for patients who are coming in with anterior uveitis. If they're coming in with their first simple, uncomplicated episode of strictly anterior uveitis, and it's not severe, it is okay to not order a lab workup for this patient if they don't have other concerning features or other signs or symptoms. If you're walking into my clinic, you have 1+ cell in the AC, your eye is red, I do a good dilated exam on you, the rest of your eye is fine, you've never had this happen before, I take a good look at the other eye, I don't see anything unusual in the other eye, you're healthy, you haven't engaged in any risky behavior, I think it's okay to not order a workup for that patient, to treat them with drops, follow them closely, and by drops I mean topical steroid plus or minus cycloplegia. Have them come back, take a look, are they getting better? If they are, great, we don't have to pursue an aggressive workup. If you're coming in and you have a severe bout of inflammation, if you have involvement that extends beyond just the anterior chamber, if you have other medical conditions that may be associated with uveitis or other symptoms, for example, like this patient, if you have this stiffness that is worse in the morning that gets better throughout the day, if you have a lesion on your genitals that just showed up, if there's something else going on systemically, I will order a workup for you. Sometimes these patients come to our clinic referred by someone else, and they come in having potentially read a lot about anterior uveitis. And this may be an uncomplicated case of anterior uveitis, but if you as the patient want the workup, if you want to be sure that you don't have syphilis, for example, or sarcoid, or TB potentially, especially if you're coming from an endemic area or have other signs or symptoms that may be consistent with TB, I don't mind ordering a workup for an uncomplicated episode of anterior uveitis. It's not wrong to do that. But it's also okay not to do it in a patient who doesn't have other concerning symptoms. If I am going to order a workup for a patient, I like to do a targeted workup. I don't like to order the uveitis panel. In fact, there really should not be a uveitis panel because every patient is different and we have to be able to interpret the results of the labs that we order. And sometimes if you order a test and we have trouble interpreting that test, and let's say we don't address this abnormal test being positive, and the patient later ends up showing up with some other disease that we could have identified earlier, that potentially puts you in a difficult situation where we really should have managed this better at earlier onset. Second, I don't want to miss ordering tests that are important. For every anterior uveitis case, I will order a syphilis test, tuberculosis test, and I will consider sarcoid. Now, the workup for sarcoid can vary based on different physicians, but I like to get a chest x-ray. I think that's easy to get and can help show us signs of sarcoidosis. If you have an alternating case of uveitis like this, where sometimes it affects one eye, sometimes the other, I will order an HLA-B27, especially if you have back pain. And if you have bilateral anterior uveitis, I will order a test called urine beta-2 microglobulin and consider some serum chemistries and urine chemistries as well to consider a rare cause of uveitis, but a cause that seems to be increasing in prevalence potentially, called TINU.
I'm glad that we talked about the infectious and the non-infectious testing. And then you did mention that if you're concerned about a lens-based uveitic pathology like uveitis glaucoma hyphema syndrome, UBM could also be considered. We briefly talked about the treatment of anterior uveitis with topical steroids and cycloplegia. When would you consider escalating a treatment? These patients often present to a comprehensive ophthalmologist. When do you recommend these patients be referred to a uveitis specialist to consider potential additional treatments?
I think this really depends on the comfort level of the ophthalmologist who's managing this patient. So, if you work in an area where you don't have, significant access to a uveitis specialist, for example, and you're used to managing these patients on your own and you feel comfortable doing it, then I think that's totally fair. However, if a case becomes complicated, if it's not behaving normally, if you put this patient on topical steroids and initially they get better and then they're getting a lot worse, or there's something unusual about their history, or you see these findings in the eye that you can't explain, I think in that case it's a good idea to try to refer to a uveitis specialist to see if there's something that you may potentially be missing in your evaluation of this patient. But ultimately, I think it depends on the comfort level of the ophthalmologist who's managing the patient.
I think my mentor, Dr. Suler, would say that if you're generally having more than 3 flares in a given year, especially with HLA-B27 positivity, I think it's very reasonable to consider therapies beyond topical steroids. And so going back to our patient, your lab tested returned with HLA-B27 positivity. You ruled out syphilis and TB. What is the typical demographic for HLA-B27 patients?
So classically, we think of HLA-B27 as affecting young men. It can really affect anybody. And I think when you've been in medicine long enough, you learn that there are many exceptions to the rule. We tend to think of it as happening in young men, but it can occur in any age group, in both men and women. These patients, on average, tend to be in their 30s or 40s. But again, they can present a little bit younger or a little bit older.
Great. And we mainly talked about the importance of the association with seronegative spondyloarthropathies. So think about ankylosing spondylitis, think about IBD, reactive arthritis, psoriatic arthritis, and you did say the importance of getting the rheumatologist involved and the importance of co-management of the condition. So let's summarize what we learned from Dr. Moussa. Acute anterior uveitis presents with eye pain, redness, and photophobia. Exam findings include decreased visual acuity, low IOP due to ciliary body inflammation, and we talked about the fact that if you do see some cells in the anterior vitreous, this is common. If the predominant site of inflammation is in the anterior chamber, this is an anterior uveitis. The hallmark findings are anterior chamber cell and flare, which are graded using the Sun criteria, and flare occurs due to leakage of proteins into the AC, and we talked about the fact that it could lag, so following the cells is important. Other findings that may be seen include choretic precipitates, posterior synechiae, which indicates prior bouts of inflammation, hypopion, and iris nodules. The large or mutton fat choretic precipitates and presence of iris nodules can suggest a granulomatous process, such as sarcoidosis. Non-infectious uveitis is more common than infectious, and about half of the cases are idiopathic. We talked about the HLA-B27 association being common, especially in recurrent and bilateral alternating cases, the key being alternating here. Think ankylosing spondylitis, reactive arthritis, psoriatic arthritis, and IBD in these patients. A first episode of non-granulomatous mild unilateral acute anterior uveitis with no systemic symptoms requires no workup, but a targeted workup is key in patients who have more severe symptoms. Rule out syphilis, TB, sarcoidosis, obtain a B27 test, and consider adding the TINU if the uveitis is there, especially with concurrent disc edema. Management of these patients starts with frequent topical steroids and cycloplegia to prevent synechiae formation and reduce the photophobia. And glaucoma, cataract, cystoid macular edema are a few complications that can be seen, so it's important to follow these patients closely as we taper the steroids and educate them on signs of recurrence. Most patients with anterior uveitis who have rare flares can be managed by a comprehensive ophthalmologist and referred for complications of the disease. But if the flares become frequent or there's something that doesn't make sense from a management standpoint, then a uveitis referral for consideration of initiating immunomodulatory therapy or additional workup can be pursued. Dr. Moussa, anything else you'd like to add?
I think that was you did a great job summarizing that, Dr. Uner. Nicely done.
Thank you. And Dr. Moussa, before we end the episode, I ask all of my guests a question. My question for you is, if you could go back in time and give your younger self one piece of advice, what would it be?
That's a difficult question to answer, Dr. Uner, but given this podcast is probably geared towards trainees, medical students and residents and such, I would say going back to that phase in my life, I would probably tell myself to try to live a little bit more in the moment, to try not to rush things very much. Often as trainees, we are looking ahead at the next step, trying to plan things well in advance. When I get done with medical school, I'm going to go to residency, then I'm going to do this fellowship, then I'm going to get this job. And it can be easy to lose sight of where we are in the present. So, despite our very busy schedules and all the patients we're seeing on call as a resident and such, I would say I'll tell myself to try to really live in the moment and enjoy those years of your most interesting life.
That's very inspiring, and I think all of us could do a better job of doing that and making sure that we, enjoy and learn the most, and to feel like we are really privileged to be in this job, taking care of these patients, and we're growing with them. So thank you so much for that response. And Dr. Moussa, thank you for joining us on this episode of the Pupil Pod.
Thank you very much, Dr. Uner. Pleasure to be here.
And thank you to our listeners. See you next time on the Pupil Pod.